So in this video we are going to talk about breech birth and some other malpresentations. We have talked about some malpresentation already, so we might not repeat them in this session. So by definition, what is malpresentation? We talked about this and we said it's where the fetus is lying longitudinally but presents in any other manner apart from vertex. So it can be a breech presentation, a face presentation, a brow presentation, shoulder presentation, compound or cord presentation. But there should be a clear difference between breech presentation and malposition. You have to be able to differentiate these two terms, because for malposition is where the fetus is lying longitudinally and the vertex is presenting, but the position of the fetus is not in the anterior posterior position. Okay? For example, when the fetus is in the occipito-posterior position, that is a malposition. Okay? Occipito-transverse position, that is a malposition. It can be left occipito-transverse or right occipito-transverse. Okay? Just a few examples here of fetal presentation. You can see in vertex presentation, the presenting diameter of the fetal head is suboccipito-bregmatic, which is around 9.5 centimeters. Okay, you can see suboccipito just beneath the occiput, bregmatic to the bregma. Okay, when the presentation is sinciput, the presenting diameter is suboccipito-frontal, just beneath the occiput to the frontal bone. Okay, and it's around 10.0 centimeters. In broad presentation, the presenting diameter is mento-vertical, which is around 12.5 centimeters, and for, you see, mento-vertical from the mentum to the vertex. And then for the face presentation, the presenting diameter is submento-bregmatic, submento just below the mentum, bregmatic to the bregma, and it's also around 9.5 centimeters. Now let's talk about breech presentation itself. What is breech presentation? As we said before, it's where the fetal buttocks or lower extremities present in the maternal pelvis. And there are different types, as we already looked at them. We are not going to dive so much into the types and explanations because we talked about this before. We have frank breech, complete breech, footling breech. You can see this is footling breech, where one foot it's leading. Okay, this can also be called a complete incomplete breech. Then you have a complete breech, Then we have a frank breech where the hips are flexed but the knees are extended. So how do you make a diagnosis of a breech presentation? During your obstetric assessment, when you are performing Leopold's maneuvers, the abdominal assessment you do on a pregnant mother. For example, during third trimester, when the mother has come for maybe her antenatal care or like that, you can actually make your palpation and have a prediction of a breech presentation that you can later confirm with the obstetric abdominal ultrasound scan. Sometimes you don't need to confirm, but if you have the facilities, it would really help you to confirm. Okay, because when you are doing abdominal assessment, the presentation is one of the parameters that you assess. You check for the presentation, the position, the engagement of the fetus during the maneuvers. Okay, again, as you can see, when you are doing abdominal palpation, you know the presenting part. Okay, and you'll be able to make a decision on the lie of the baby and even the position. Now, after diagnosing breech presentation, how do you manage breech presentation? So if it's possible and you have made a diagnosis of breech presentation, yes, you have to refer to a level of care where they can manage breech, but also in case the management phase, other interventions can be made. If you don't have the skills and expertise, then refer or look for an healthcare worker who has the skills and expertise in delivering breech. Okay, but if you have the skills and expertise, then you have to deliver with it. Depending on the type of breech, that will determine the maneuvers that you have to use. But you should know that in breech delivery, there is a possibility of head entrapment when the baby is in a breech presentation. So, depending again on the size of the baby, the size of the fetus, you do not want to deliver a breech baby in a level of care which is maybe a BIMAG facility, and you are worried of the risk of head entrapment. Okay, now at birth, what are you going to do? Assuming you have the experienced health care provider in breech delivery, ensure there is also an experienced health care provider in newborn resuscitation, because there are chances are high that the baby could present as fixated. Okay, that might need a resuscitation. So ensure that experienced healthcare provider in resuscitation is available, but also ensure the bladder of the mother is empty, because you know how full bladder interferes with the descent of the presenting part of the baby, but also it interferes with the entire birthing process. Explore the perineum and decide if episiotomy is needed. If the perineum is very tight, then you might need an episiotomy and you have to prepare for this. If you might need a forceps to help you in the delivery, then explore that and ensure it's available. Okay, in case the head might get entrapped when you are conducting the breech delivery. So when you are doing a vaginal breech delivery, if you can see in this photo here, if the infant is premature, that infant most likely will just deliver spontaneously. I remember my first breech delivery was a premature infant, and the infant just came. Okay, the baby just came without much hassle. But for term babies, they might be a little bigger and they might get stuck. So you should be able to know the maneuvers that you are going to use, that we are going to discuss shortly. Ensure you support the legs and the trunk, okay, as they merge, just supporting, okay. But also hold the baby by pelvis. Don't just hold the baby anyhowly, but you have to hold the baby by pelvis using the technique that we are also going to describe shortly. So now, technique for breech delivery. First, explain to the mother why she should push effectively and the technique of pushing effectively in second stage of labor. Train the mother on how to push, okay. Sometimes we assume that a mother is a gravida too, so the mother had a vaginal birth before she's experienced, but that assumption is not always true. You have to talk to her and guide her on how to push effectively. Ensure there is adequate analgesia. Unfortunately, in our setting, it's rare, but this is highly recommended. Mothers don't have to undergo very extreme pain, because currently we have modalities available to manage pain during pregnancy, during birth. There are modalities available, and this should always be factored in when you are managing a mother. Yes. So, thirdly, spontaneous descent and expulsion to the umbilical should occur with the maternal pushing on. Don't pull the baby anyhow. Allow the baby to descend with the maternal expulsion until you reach the level of the umbilicus. That is when you are now going to support the baby, and you will hold the baby from the pelvis, not from any part of the body. The baby should be supported in a horizontal position or allowed to hang until the nape of the neck appears at the introitus, just as you can see. So if you choose to allow the baby to hang, let the baby hang until you see this part, okay, until you are able to see the nape of the neck here, and then you can now hold. Again, very important, do not pull on the breech anyhow. Do not pull. Okay. Then fourthly, rotation to the sacrum. To the sacrum anterior position is desired and may be facilitated. Okay. If you can see from this photo, okay, the baby is in the sacrum anterior position. The sacrum is in the anterior aspect of the maternal pelvis. That is what we mean. So if that does not occur spontaneously, then you can support by performing the rotation, as you can watch from the video below. I am not going to show the video, but when you receive the slide, you are going to watch and then you compare with the notes. Episiotomy may be considered once the anterior buttock and anus are chroning. Okay, if the perineum is tight, the anterior buttocks and anus are chroning, then you can do episiotomy, but of course under adequate analgesia. Do not attempt to extract the legs until the popliteal fossa are visible. Again, the techniques are very clear in the videos. Do not force, do not extract the legs until you can see the popliteal fossa, because you are going to flex. You are going to flex the legs at the popliteal fossa, and then you sweep and then you extract. So you can't really do that until you are able to see. So if you can see in this photo, the midwife, the nurse midwife, the healthcare worker is supporting the baby, but is holding the baby from the pelvis, not from any part of the body, not from the abdomen. Now here the health worker is rotating, as we talked about the rotation of the baby to ensure maybe it's in the sacral anterior position. It's still doing the rotation. Okay, if you can see in these photos. You see, this one is in the, is not in the sacral anterior, so that means needs to be rotated. And then for this photo, okay, it's not so clear, but what you should know is that you have to support the baby to maintain the head in a flexed position. Okay, remember flexion, ensure the head is flexed, because even when you're going to deliver the baby, you have to keep the head flexed and it will come out a little bit easily. You can apply suprapubic pressure but not fundal pressure. Fundal pressure is highly discouraged in most cases. Maternal expulsive efforts should be encouraged. Okay, should encourage the mother to push the baby by her own expulsive efforts. So these are some of the maneuvers that you are going to perform, but they are going to be clearer in the video, okay, where you are going to deliver the legs, as you can also see in this second photo. So one of the maneuvers is called the Pinard maneuver, which is accomplished by inserting two fingers. You insert your two fingers along one extremity to the knees. You'll follow one of the limbs or the legs, and then you reach the knee. When you reach the knee, you will now push that leg away from the midline. That is abduction. At the same time as flexing the legs, flexing the leg at the hip. So you will push the leg away from the midline, but you flex the leg at the hip. When that happens, it will cause spontaneous flexion of the knees, and then you can deliver the food. Ensure you support the baby around the hip and have the woman push until the scapulae are visible. We talked about this. Remember not to hold the baby by flank. Okay, not to hold the baby by flank or by the abdomen. Why? Because if you do this, it might cause injury or damage to the kidneys, the liver, or other abdominal organs of the baby. So don't do that. Hold the baby by the pelvis around the hips. Okay, do not pull on the breech or compress the woman's abdomen. Don't do this. Maintain flexion of the fetal head by keeping the body below the horizontal plane. If you remember that photo where the baby was hanging, was left to hang freely, when you do that, the head of the fetus is kept flexed. Okay, yes. So number 8, rotate the body to facilitate delivery of the arms of the chest. That is the Lovset's maneuver. So the Lovset's maneuver involves rotating the baby to facilitate the delivery of the arms over the chest. So you can rotate the baby and then you deliver the arms. Okay, still by flexing from the cubital fossa, and then you sweep over the chest, and then you deliver the arms in case they do not deliver spontaneously. Now for Marie-Cis Mielivete maneuver, ensure you maintain the head. Still, we are talking about this time and time again, because this is the maneuver that you use for delivering the head of the baby when the rest of the body have been delivered already. You keep the head still flexed by placing your hand, okay, your finger over the chin, as you can see here, your finger over the chin and molar prominences. Okay, we are going to do this practically in class, but you'll You'll first watch it from the video I've shared and from other videos I'll share, but also we shall do it practically in class so that we are able to appreciate it more and more. Okay. So one finger will be on the chin and then on the molar eminences, and then your assistant may help in the delivery by providing a suprapubic pressure. Suprapubic pressure just above the symphysis pubis on the abdomen, but not a fundal pressure, and this might help deliver the baby. This other hand will support from this side. Okay. As you can see here, and then you deliver your baby. Now after conducting a breech delivery, what are you going to do? Still, you are going to prevent postpartum hemorrhage by doing active management of third stage of labor. Ensure you are ready for newborn resuscitation and you conduct it when necessary. But sometimes we encourage, most especially in facilities with some of these investigations, to do umbilical artery blood gas analysis, and most especially when you feel the baby score was not very okay, to rule out birth asphyxia. Examine the mother for trauma if there were any perineal tears, and then you repair, but also do a thorough examination of the baby for any possible trauma, and if you suspect a trauma, ensure the baby is reviewed by the neonatal team or the neonatal specialist. Do not forget to examine the hips of the newborn. Okay. Just after birth, when you are doing the initial newborn examination, check on the hips if there could be any damages. Apart from the initial immediate newborn exam, ensure you repeat the examination. Okay, repeat the examination of the newborn when you are doing the comprehensive neonatal assessment before you discharge the mother and the baby home. Yes, so we are done with the brief presentation, but you are going to appreciate the maneuvers when you watch the video and when we are doing them practically. We also talked about face presentation. I'm not going to talk about the explanation because we explained this earlier, but maybe we can talk about the diagnosis. It's generally diagnosed on vaginal examination. When you do a VE, when you do a vaginal examination when a mother is in labor, you can make a diagnosis of face presentation. Sometimes you might confuse it with the breech presentation, but these are some of the landmarks or the reasons that should help you to differentiate it very well. Because with the face presentation, you can actually pop your fingers into the mouth of the baby, and when you do that, the baby will start sucking your mouth. Okay, that one can help you also rule out. But for breech presentation, you can pop your fingers into the anus of the fetus. So you have to know that the anus has a sphincter tone, and that one you are going to be able to feel it. But the mouth doesn't have. The mouth of the baby, of the fetus, will just be open, or the fetus will just suck on your hands. But the anus is also lined with the ischial tuberosities. You should be able to feel this, while the mouth just forms a triangle with the malar prominences. So you'll be touching the molars of the baby and the malar prominences of the fetus. Yes, you can touch it, but also when you pop your hands into the mouth of the fetus, you can be you can feel the gums, okay, the gums of the fetus that can also help you rule it out. So this is how face presentation might appear. So when you do a VE, you can touch on the mother prominences, the mouth and things like that. How do you manage? If you make a diagnosis of face presentation, you can start an IV, put an IV line and start IV fluids to prevent maternal dehydration and ketosis. Ensure you use a pathograph, okay, or a labor care guide for progress assessment. Check on the fetal heart continuously and provide adequate analgesia where guidelines allow. Ensure you observe the baby regularly for maternal and fetal conditions. Prepare for a cesarean section. Prepare for the operative intervention. Ensure the neonatologist is informed, the obstetrician is informed, the anesthesia team is informed, and the operating theater staff are informed. Sometimes face presentation can actually the presentation can change and the baby can be delivered vaginally, but in most cases they cannot be delivered vaginally and they have to undergo a cesarean section. But it's important to monitor the progress of labor. It's important to monitor the fetal heart, and it's important to manage this baby collaboratively, not alone as a midwife or as a nurse. Then for cord prolapse, I know a group is going to talk about cord prolapse extensively, but it's basically when the cord is on the presenting part of the baby. And these are some of the risk factors for cord prolapse: when the cord is very long, or when the baby is premature, the baby is very small. And also for mothers with the multiple gestation. How do you manage cord prolapse? Ensure the mother is on Trendelenburg position, that is the niches position, to relieve pressure on the cord. Okay, don't tell the mother to push the baby. Okay, that one shouldn't happen. The rescuer may need to reach inside and manually lift the limb of the cord, most especially if one of the limbs or the fetal part is compressing on the cord. You might have to relieve that pressure manually. So ensure you maintain this niches position until you reach the next referring unit, or you reach the theater, or wherever the mother is going to receive care from. I think that is basically about breech presentation and other malpresentations. Now, for shoulder presentation, we also talked about it. So in this video, I am not going to exhaust it so much. Yes, but we say the shoulder presentation occurs in transverse lie. Okay, and you know, in transverse lie, the long axis of the fetus is perpendicular to the long axis of the mother. But in shoulder presentation, the shoulder of the baby comes in the lower segment of the uterus and occurs in 5%. So as you can actually see in this photo. So how do you make a diagnosis of shoulder presentation? Again, you are going to do an abdominal examination. The head is usually felt in one iliac fossa or in the flank. You can feel the head, but not as a presenting part. But on the side, you know, with the transverse lie, the head will either be on the left side of the abdomen or the right side of the abdomen at the position of the flank. Yes, the breech can be in the other iliac fossa, or at a higher level, can even be at a higher level. Then the fundal level might just be above the umbilicus, because the baby is lying transverse, so most of the fetal part is running from the left and to the right aspect of the mother, or the mother's abdomen, not from the symphysis pubis to the fundus. So the symphysiofundal height will be a little shorter than usual. Fetal heart sounds may be heard below the umbilicus. That could be one of the indicators, as you can see from these hands palpating the baby, and it is a transverse presentation. So on vaginal examination, in early labor, you might find that the cervix is still very far elevated and the lower uterine segment is imperfectly filled. It's really, you can't really feel the presenting part so well. Now later in labor, you might feel the cervix is not dilating as required. Why? Because there is no presenting part exerting any pressure on the cervix. Okay, still on that vaginal examination in late labor, you might actually feel the scapula or the acromion or the clavicle, the axilla ribs of the baby. How do you confirm the position? If the arm is prolapsed and supinated, for example, if the arms as one of the arms has prolapsed and it's coming down, so you might find that the dorsum, that is the back part of the arm, is pointing to the back and the thumb points to the head. As you can see from a photo below, the dorsum pointing to the back and then the thumb pointing to the head. How about in early labor? So we are done with that in early labor, late labor, and how you can confirm the position. I remember we talked about this term neglected shoulder. We talked about this in our class presentation. These are some of the features that can help you maybe make a conclusion that this was a neglected shoulder. When the mother had prolonged labor, the membrane was ruptured, the liquor was drained, the arm is prolapsed, the fetus is dead or almost dying, lower segment overstretched. That means the mother was not properly attended to, and there could also be signs of obstructed labor. As you can see in these photos. Now we are saying in modern practice, persistent transverse lie in labor is delivered by a cesarean section, whether the fetus is alive or dead, because there is no way it's not really very easy to bring that fetus to deliver by vaginal birth. In most cases, or all cases, the fetus will be delivered by a cesarean section. Now for compound presentation, we also talked about this, so I'm also not going to focus so much on it. But for the diagnosis of compound presentation, when active labor is arrested, okay, when the fetus fail to engage, and when the prolapsed extremity is palpable. We say compound presentation is when an extremity, that can be an arm or legs, but it's common with the lower legs, prolapses. Okay, prolapses alongside the presenting part. Spelling is not correct. Prolapses along the presenting part. So both the prolapsed extremity, the arm or the leg, and the fetal head or the fetal presenting part present in the pelvis at the same time. That makes it very difficult for the labor to progress. So you'll find that the labor, the active labor is arrested, no progress, no descent, no cervical dilatation, no engagement. Okay, but you can also palpate the presenting part. How do you manage? Don't manipulate the prolapse extremity. Don't manipulate it anyhow, because in most cases that extremity will actually spontaneously be pulled back and away from the presenting part. In most cases, and in 75% of them, but in 75% of the upper extremity presentation, spontaneous delivery will occur. But most importantly, you have to continuously monitor the fetal heart rate, yes, so that in case there is any deviation from the normal, maybe there is bradycardia or tachycardia, appropriate decision can be made by the team. What do you do? When do you do a cesarean section? If you find non-reassuring fetal heart rate, you have to make a decision for a cesarean section. The obstetrician is around. If there is cord prolapse, that mother might benefit from a cesarean section. The baby might benefit from a cesarean section. Or if the labor has failed to progress, you tried managing conservatively, but labor finally failed to progress, then you can also consult the team for a possible cesarean section. Basically, that is a presentation about breech and other malpresentations, but the main focus of this presentation was breech presentation, and you should be able to know how to make a diagnosis of a breech presentation and also manage deliver a mother with a breech presentation using some of the maneuvers we have talked about. Most importantly, watch the video. I'm going to share other videos on email and maybe through your class coordinator and on your platforms so that you are able to go through them.